if that's okay, Chris.
Yeah, well, I've now.
Are we ready to go?
Yeah, well, I've now.
Great. Right. Thank you, ladies and gentlemen, councillors. Welcome to the Scrutiny Committee for October. There's just somebody's just joining us there. If we go before there's a couple of new members on the committee, and I would just like if we could go around and introduce ourselves so everybody knows everybody else. I'm John Bainan. I'm the new chair of this committee, and if we can just go in turn and we can all introduce ourselves, please.
Chair, we don't know what you mean by different places on the board. So
I think it might be easier if you go through that list, Chair.
Sorry, Chris, I missed that.
Sorry. I said it might be easier if you go through that list that I sent you.
Right. Yeah, here we go. Now, the only list I've got is obviously the councillors, Eileen Armstrong, Les Bowman, Councillor Sesford, Councillor Dunwood, Councillor Hutchinson, Councillor Lorry, I haven't seen his face yet, Councillor Nesbitt, Councillor Rigby, and Councillor Simpson. We're all present. Haven't seen Councillor Lorry.
You might want to say my name correctly, Chair, for the record.
Dungworth?
Yeah, thank you.
Sorry, did I not say that?
No.
Sorry, I apologise. Everybody gets my name wrong as well, so I know the feeling. Great. Have we any apologies, please, Chris?
Do you want me to do that, Chris?
Yes, please, Heather.
No apologies received, but note that Councillor Lorry is absent.
Great, thank you for that. If you note on the membership, we have myself and Councillor Lorry, and we are replacing Councillor Watson and Councillor Patterson. Item number 3, disclosure with members' interest. Have we any? No? Item number 4, forward plan, which is Appendix A in the agenda, and I believe, Chris, you'll be taking this?
Oh, well, thank you, Chair. The forward plan is there just to note the key decisions coming to Cabinet between September and December. There isn't anything on there coming directly from the Health and Wellbeing Scrutiny.
Great. Anybody want to make any comments on that? Oh, great. Item number 5, report on the update of COVID, and Liz Morgan is here, Director of Public Health. I'll hand it over to you, Liz, please.
Thank you very much, Chair. So I'll try and make this brief. So over the last 7 days, we've had 522 cases reported for Northumberland residents. That is probably the highest 7-day number that we've had. And as you will have realised, there has been a bit of an issue about data transfer. So last week, the number of cases looked as though it was dropping off quite significantly. I think we had some suspicion about those statistics, and that was proven to be correct, because it subsequently became apparent that 16,000 tests hadn't been pulled through correctly into NHS Test and Trace. So for Northumberland, that meant another 207 cases to be added to our collection. And that meant that actually, rather than cases dropping, the best we can say is that the rate of increase is not quite as great as it was. So still very concerning at the number of cases and the extent of community transmission. In terms of the age groups that are being affected, it's sort of remained fairly consistent. So about 40% of cases are in people aged between about 30 and 64, about 40% between the ages of 18 and 30, and between sort of 8 and 13% in children under the age of 18, and a similar number in older people. But obviously the numbers are increasing across all age groups, and that is being reflected nationally. In terms of the geography, still largely concentrated in the southeast, but I think I described the southeast as becoming larger. So it is, you know, we are getting more cases going up the coast, had a handful of cases in Alnwick and Amble, and again, more cases, or continuing to get cases along that A69 corridor, and a smattering of cases in our most rural communities. So that's what the general picture looks like. In terms of care homes, we have had a handful of outbreaks in care homes over the last week. One of them is quite significant, is affecting, you know, a reasonable proportion of staff and patients, and we're managing those. And of course, we're now entering into the winter season, and we can expect to see, as we would normally see, outbreaks of diarrhea and vomiting and other influenza-like illnesses. Although, you know, you like to think that with the level of personal protective equipment and the infection prevention control measures that we've got in place in care homes, and all the support that we've got in place for those settings, that actually that would also reduce other infectious diseases as well. From a schools perspective, again, over the last week, we've had over 60 children who have tested positive. In terms of the schools affected, you know, that reflects community transmission. Again, largely schools in the sort of central and southeast of the county, mostly single cases, but we do have, again, a handful of schools that have got more than one case. And I think we've got about 3,000 children at the moment that are self-isolating at home because they're either cases, or they are, you know, they've been sent home because they're part of a bubble. So that's obviously having a significant impact on schools in terms of both disruption of education, but also in terms of the amount of pressure being put on head teachers to continue to keep those schools open. We've started to do some enforcement work over the weekend. So our public protection team was out on Saturday working with businesses in Ashington in particular. I think overall those visits were met very positively. I think businesses appreciated the opportunity to have a one-to-one conversation with some of our public protection team, and to get some individual advice for their particular businesses. It was raining quite heavily, and of course Newcastle were playing Saturday evening, so the hospitality venues that they visited were not quite as busy as one might have expected them to be. But actually the control measures that they had in place were really good, and there weren't too many issues to follow up. Our community hubs, so Northumberland Communities Together, they were also out doing a pop-up event in Manor Walks. Again, that was received really positively. They made contact with over 400 people to provide advice on how to stay safe from coronavirus, and also identified a number of individuals who would benefit from support from the team. And because of the success of that, they've the likelihood is that they will roll those pop-up events out to other towns. Clearly, there are, with the introduction of the new regulations, there are a significant number of issues around how we interpret those, particularly around sort of physical activity and the use of gyms and, you know, community halls to support classes. And we're just trying to come up with an agreed consensus on the interpretation of those regulations, so that we can make sure that those messages are consistent. In terms of the NHS, we have seen an increasing number of admissions to, well, both nationally and locally. So I think admissions went up by a third between this Sunday and the Sunday before. I think the impact on the NHS is going to be significant, not actually just because of admissions, but I think there is going to be pressure because of the impact on staff, because so many of them may be required to isolate because they themselves have coronavirus, or because they are a household contact of somebody else who has coronavirus, or because they need to undertake childcare activities. And of course, the regulations restrict childcare support to you know, for instance, one set of grandparents, not both sets of grandparents. So I think, you know, that potentially there are direct and indirect effects on the NHS, and indeed on our own workforce. And we're finding that, you know, actually there is some pressure on our own staff because of their need to self-isolate or to support childcare. And just going back to the regulations that were put in place, probably just worthwhile mentioning that those restrictions did come with a significant financial request for support, which we're still working through with the government. There is some funding has come through, but we're still working with the government to pursue the rest of the ask that we made. That's probably about all I wanted to say, but obviously very happy to take any questions should anybody have any.
Thank you, Liz. That's always a very good report from yourself. Councillors, any questions for Liz? I can't see anybody indicating. Chris, can you see anybody I might have missed?
No, I can't see anybody. Heather?
No, I'm looking. I can't see anyone indicating. No.
Thanks, Heather. Great. Liz, thank you very much once again for always giving a very good debrief. And hopefully we'll be seeing you in the very near future at probably the next full council, I would suspect. And I know you want to get away because you have another meeting to go to, Liz. Liz seems to have frozen. Yeah. Chris, can you hear anything from Liz?
No, I think she's frozen.
Frozen, yeah. Great. Well, thanks for that, Liz, if you can still hear us. We go on now to item 6, quality account presentation. That's appendix B in your agenda.
Yeah,
Arrived.
I don't believe Lisa's here yet, Chair.
Okay,
No.
we'll come back to that one. Do we want to go to item number 7, NHS winter plan presentation, please?
Hi everyone, my name's Laurie Robson. I'll be presenting today with Bijou Bartoli from Northumbria Healthcare. I'm assuming everybody has a copy of the slides, so I'll just talk my way through them.
Yeah,
in the planning process this year, we've put a significant focus on partnership working. This is imperative for us to tackle winter. All partners, the acute trusts, the ambulance trusts, primary care, social care, and our out-of-hours providers have formed part of this process. So not only have we developed a robust plan at a local level, we've worked collectively with all of our partners at an ICP level and at a wider regional integrated care system level as well, to ensure we have a really robust plan across the region. So each stakeholder shared their plans in June, July time, and it was a really good opportunity to do a check and challenge, identify gaps and work out how we can close them. So most importantly, it was to develop a shared understanding and confirm how individual plans fit together as a system. The premise of our winter escalation plan is we needed to be prepared as possible for a different type of winter. So offer escalation gearing that recognises the difference between a COVID winter, so a winter plan that includes social distancing, COVID surge, so a surge in COVID cases, as we've been seeing recently in the northeast, but also a COVID surge winter, which takes into account both of the above. So in order for this to work effectively, we've looked to agree mutual aid in advance, so a really clear understanding of the process and how that would work. And in addition, through system working, we're really clear in terms of when one provider escalates, what the impact will be on the other. So to look at this in a little bit more detail at stakeholder level, some of the work that we've carried out with primary care is outlined on slide 4. So the key updates include the way we work with our practices in terms of how they report to us. So we've made some amendments in that process to allow us to monitor the impact of COVID more robustly. We've looked at how services continue to be fully supported by digital alternatives, but taking into account that the telephone communication must be maintained for those with, who are digitally disadvantaged. We've looked to refocus our extended access appointments in the support of delivering the flu vaccine problem. Reflecting on previous experience of COVID, we've ensured that PPE stocks are available to ensure the recovery of services is maximised where they've been impacted by this previously. We've continued to focus on vulnerable patients and prioritise the shielding arrangement that's previously been in place. So we'd look to re-establish this at a local level should that be appropriate. In addition, we've reviewed our face-to-face appointments and where we may remobilise hot sites should that be required during times of escalation. In addition to this, the primary care colleagues have worked really closely with the Northumberland Flu Collaborative Programme to really ensure that we can maintain this focused uptake for our patients in terms of making sure that we hit the 75%. We've done a lot of work with our community pharmacy colleagues in terms of making sure their continuity plans are robust and strengthened where appropriate. We've worked really closely with 111 to ensure that patients are signposted to the appropriate location and also that there is an opportunity for them to access urgent medicines. In addition, without reiterating too much of what's been done with primary care, we've mirrored that work with our GP out of hours services as well, to ensure that their support will be continued within the Talk Before You Walk initiative. That is an ongoing pilot within the North ICP. And we've also done a lot around ensuring that rotas and capacity will be maintained, not only during winter peaks, but routinely across the challenging times. And that, again, that we've agreed this mutual aid arrangement. The next slide is more focused on the acute winter planning. So at this point, I'm going to hand over to my colleague Bijou, who will take us through.
Thanks, Laurie. Hi, my name's Bijou Bartoli. I'm one of the exec directors at the Trust, and I'm just going to talk you through the acute bit of our winter plan, which will touch on some of the things that Laurie's already talked about. You'll see in the first slide there, and this has been refreshed more recently, just to show that really our A&E attendances are back up to the level of what they were pre-COVID. So you'll see there we saw a huge drop in A&E attendances during that peak of COVID, during end of March, beginning of April, and then slowly after that time, activity has increased again. We continue to manage our A&E performance, but it is getting tighter now as we head towards winter. And throughout all of this period, the clinical teams, the major concern for the clinical teams is crowding. So crowding pre-COVID was always a concern, but clearly with the risk of COVID, it's an added concern now. And for us to try and mitigate that flow and flow through the hospital remains key. So we have a risk at the front door in terms of volume of people coming in, and if we can't manage that, that's problematic. And then likewise, if we don't have freed up beds in the system, we can't move people through the department, and that also becomes a problem. So having a appropriate bed base and very good discharge arrangements, which we had during COVID, becomes key in terms of managing that overall crowding. The next slide. So the next 6 months, what we're very focused on is clearly winter and winter pressures, and we're probably quite well rehearsed. We're always fine tuning our winter plan, but clearly, as Laurie has alluded, we've got some added pressures this time round. Workforce is something that we're watching very closely, be it through track and trace or illness themselves, in terms of having a workforce that can support our plan. And the bit that's a little bit different this time round compared to what we had in April is that there is an expectation that we will maintain all of our elective activity. So back in April, if you remember, during the level 4 incident, we were told to stop all of our elective work, which we did. This time round, we're being told to maintain as much of that elective activity, and quite rightly so, that we should be trying to do that, but that just puts an added tension in the story. And clearly, we also have infection control measures to be cognizant of, and that's not just COVID, but also the usual D&V, norovirus, flu outbreaks. We're managing all of those through this process. So our primary aim, as you'd expect me to say, is to maintain patient safety, that demand at the front door. So some of the things that Laurie's talked about in terms of talk before you walk, new initiatives to see whether that has an impact. Crowding in the emergency department, in the waiting rooms, be they of the emergency department or ambulatory care, along the ambulance corridor, and clearly maintaining flow. So if I take you to stage 1, which is the bit that we're in now, we've had a strong focus. We've worked very closely with both councils, Northumberland and North Tyneside, around length of stay. We've got quite a good system now in place that allows us to ensure that we can move people through our hospitals back to either their own homes or to care, additional care where required. We've got some escalation beds on both of our sites. We've got some, particularly in Northumberland, we've called it the Bluebell unit. It's an East Riding. It's some interim beds that we're using to help support our discharge to assess programme of work. And we've got a lot of kind of beds that we can flex, open and close, that we're using at the minute just to maintain flow through the department. I'll go to the next slide, which outlines what our kind of business as usual model is. So you'll see there's the Northumbria Ward 1, which is the 3 circles with skeletons on. That's currently the orthopaedic ward, hence the skeletons there. And we have the Northumbria Ward 9, which has a mixture of things on. It has a discharge lounge on currently. It has a psych liaison bubble, and then it has an empty 10-bedded pod. If we take you to the next slide, in COVID winter, what our plan has been is that orthopaedic ward, the 30 beds on that orthopaedic ward, will switch to a medical ward. And also some of the modelling we've done would suggest that orthopaedics can actually work out of 20 beds. And then we'll have 10 beds in the middle that we'll be able to flex depending on where the pressure sits in the system. Now, we've not done this before in a winter plan, but what we did do was use this model during the COVID peak, and we found that we had a lot more efficiency, senior input into the NSEC site for our patients, meant that they moved through our system much more quickly and more effectively. Hence why we've gone back to a model that we tried earlier on and has shown to work. In the event that there is a COVID surge, we would flip our model to what we had during COVID. So during that time, we moved surgery and orthopaedics off the NSEC site to Wansbeck to create even more bed capacity for medical patients, which is the large volume of activity that generally comes in through winter. And then we've got the final slide there, which is COVID surge winter. If it gets really, really bad, which we're hoping we won't get to this point, we can open 2 additional wards on the NSEC site. Surgery and orthopaedics moves to Wansbeck, and in effect, we start a model that was very much like what we had during COVID, which we didn't have to use because we did have quite a lot of bed capacity during the COVID peak. So it's just to kind of outline there that we've got really 4 stages that we will work our way through depending on how severe the winter pressures get. Because I think we're all, whilst we've done lots of winters before, we've never done a winter in COVID. So we really are, trying to work through what is going to come through the door and how best we manage all the varying tensions that we have. In order for that to work, we are doing some building work. We're relocating the discharge lounge. We've got some void space on the NSEC site. So we're moving the discharge lounge up there to create that space on Ward 9. We are very much tracking staff sickness, particularly watching the impact that the track and trace system has for us on that. And I think we've got a number of pieces of work that we're looking at that Laurie's alluded to in terms of Talk Before You Walk and NIAS delivering their See and Treat model again, which they used during COVID and which we benefited from. And clearly we are reliant on everybody in the system. So primary care being able to maintain their services, and the discharge arrangements that we had both at the Northumberland end of the patch and the North Tyneside end of the patch, being as efficient as they were during the time of COVID. And we've got no reason to believe that won't happen because we've been working very closely with partners. Just in terms of further systems and actions, I think that's probably just a bit of a review in terms of we're evaluating some pilots around PTS same-day discharge, the Berwick paramedic model that the CCG have commissioned. And we're trying to manage ambulance arrivals across our trust as well, because that clearly remains an issue for us to ensure we don't have crowding in the ED department. So in conclusion, I would say that the plan this time round is probably better. We've been able to refine it over time, learning really what we've learned from previous winters, but really also what we learned during the COVID period. We learned a lot during that time. We're very much dependent on system partners, and we've got good working relationships across the patch, which is really positive. And we know that where there is sometimes pressure, we can pick up a phone call and get that matter resolved. Everybody's trying to do the right thing for patients. There's clearly an impact on system plans, so we are talking closely with our colleagues in Newcastle and Gateshead from an emergency flow point of view. And we've got a big push with regards to our comms messaging, because we need the public to help us with this. So in terms of using the ED department responsibly, using other outlets, be that primary care or urgent treatment centres, ambulatory care, pharmacy, etc. So we have a strong comms message that will go out locally, but also across the region from a consistency point of view. And Claire Riley, our Exec Director of Comms, has worked closely with other partners to develop a one phrase narrative, which is that do your bit messaging that you can see on that last slide. And I'm happy, sorry, that was a bit of a rush through of what our plans are, but I'm happy to take any questions or if Laurie can answer any as well.
Great, thank you, Bijou and Laurie, for that. Really a very interesting and informative presentation. Councillors, I'm sure there's many people and many councillors who want to ask some questions. Susan, I think you had your hand up first.
Thanks, Chair. A couple of questions. One around the flu vaccine. I've been raising it for a few weeks around shortages, and I've had several contacts from residents this week that have had their flu jab appointments cancelled because there isn't the vaccines available. So I am keen to know what's happening and if those vaccines are still hitting the target groups. And the other one in relation to flu vaccination is, have we a plan administering it to the most vulnerable patients, but who might be at home? Because a lot of people have got a concern about going to a doctor's surgery or a community centre to get a flu jab. And I just wondered if we had any plans for that. Thank you. And I mean, the report was really informative. Certainly very helpful to have that clear view about what will happen at the acute level if we get to that stage. So thank you.
Okay, so Laurie may want to come in around the primary care element of the flu vaccine. Suffice to say, within the trust, we've got a target this year of trying to ensure 100% of our staff are vaccinated against flu. I'm pleased to say I've had mine, and we've already had our first batch through. So all of the board has had their vaccine done, and we're working our way through staff groups in order to make sure that that is delivered. We had good uptake last year, better than we've ever had. I think it would be fair to say that COVID has focused everybody's minds, and we've had we've not really had to push very much yet in terms of getting flu vaccinations in the hospital. But I recognise your question was predominantly for the population that don't hit our hospital doors. We will be working, before I bring Laurie in, we will be working with primary care colleagues, because some of our community services, particularly for those that are most vulnerable, will be able to give vaccinations when they go out to visit patients in their own home. Laurie, I don't know whether there's anything you can bring in from the primary care component.
Hi, Susan. So thank you for your questions there. So I think there is one key question that I'm going to take back to the Northumberland Flu Collaborative Programme. I'm pretty sure that will have a response in terms of the vulnerable patients question. So if I can take that away in feedback, I'd be happy to do that. And in terms of your other question around accessing these appointments, I do know there's a significant amount of work gone into these discussions at a local, regional and regional level. So I'm pretty sure the comprehensive plan will answer a lot of the questions. So it may be something that we may want to bring back to a future committee, if that's helpful, or circulate it for review.
Yeah, I think it's within the pharmacies, within community pharmacies, that they seem to be already experiencing a shortage of the vaccinations. And following on from my earlier comments at other meetings, I'm most concerned that our plan for vulnerability is hit first and foremost before people who may not be quite so vulnerable to all this. But equally, it starts to lose faith in a system if people have appointments that are then cancelled because the vaccinations were already run out, and it causes a level of concern in the community that is not probably very helpful.
Yes, of course. And I think, following on from what I'd mentioned earlier in the presentation, this new way of reporting that we've implemented with practices, it hopefully gives us that foresight a lot earlier. So it will hopefully prevent patients turning up expecting a flu vaccination and that then not being available. It gives us a chance to draw on the mutual aid that we've agreed in advance to ensure that we're not cancelling patients' appointments unnecessarily. But I think they really are valid questions, and I'm not really 100% the answers. So if I can check those out and feed those back in, I'm sure you'll be comfortable with the response.
That's great. Thanks a lot.
Thanks. Yeah, we'll feed the answers back. Thanks for those questions, Susan. Les?
Thank you, Chair. Thank you for the report. It was excellent.
Yeah.
I need to ask a question about discharge. Say if you had an old person who is COVID-19 and was physically fit, but obviously suffering with COVID-19. In normal circumstances, if they didn't have COVID-19, they would go into a care home. What would be the plan of action in this situation? Would they stay in hospital, or would they be placed somewhere else? What's the plan of action in these dire situations?
Okay. So there are a couple of things. Our infection control team work very closely with the homes in Northumberland. David Tate, who is our Director of Infection Control, he has a good working relationship, I think, with all of the homes, and particularly during the height of COVID, he did a number of webinars with the homes to help them with their infection control practices and what and how to manage patients who may have COVID-19, who wouldn't need to necessarily come to hospital. In the particular example you outlined, if there was a patient who had come from a care home and was COVID positive and ready for discharge because they were medically fit, there would be one of two things that could happen. There'd be a conversation with the home to say whether they were able to accept that patient back in the home and isolate them for 14 days. And David, who's our infection control director, will talk them through what kind of extra precautions they might need to take if they were unfamiliar with that. Or if the home were unable to isolate that patient, which many homes were able to do, then we would find an interim placement where they could put that patient 14 days before they would be moved back to their normal home of residence.
Thanks.
Unfortunately,
Thank you very much
that
for
is
that.
during the height. Once medically fit, we wouldn't be able to hold patients for those additional 14 days because clearly there's a pressure on the front door.
Yeah, thanks for that. Les, is that any supplementary, Les, or are you happy with that?
Yeah, well, I understand the answer and I appreciate it. I'm a bit concerned that COVID-19 residents are going back into care homes, but I'll question that at a later date, Chair. But it was interesting.
Yeah.
But thank you very much.
Thanks for that, Les. Any other councillors? I can't see anybody else. Chris, can you see any councillors that I might have missed too?
Chair, Councillor Leslie Riggerby wishes to speak.
All right, carry on, Leslie. I can't see you.
Okay, thank you. Yes, I noticed that you said that the activity had increased at the A&E, and that was a concern of mine, as with many other councillors before, of people not wanting to go into the hospital. But I suppose it's just I want some reassurance that the talk before you walk is very, very good. But are you convinced that people are aware of that facility? And do you think it needs to be highlighted or forgotten the word I want, people need to be told about it so that they can actually access help?
Other services. So I'm sure Claire will want to come in here because she's part of the regional comms, but I'll just kind of, we've only done a soft promotion, so you're absolutely right. We haven't made a big thing about it yet. Claire will come in on some of the timings of how we launch that, because we are bound a little bit by the national programme of how far we go with some of the comms at this point in time. We are trying to ensure that patients really are, what we want to do is to help them get to the right place first time, rather than them come to one site and us say, no, you've come to the wrong place, you now need to go somewhere else. But we're trying to balance that as well with potential overcrowding in any waiting room, because I think that's one of our biggest concerns. But Claire may want to come in on the comms component of that.
Yeah, and thanks for the question, Councillor Rickaby. We've had to do it really carefully just in the north of our patch, so that's the Newcastle, the Northumbria and the gated area, because that is a pilot which was initially started probably about 4 to 6 weeks ago now. The idea is that will be more widespread from the 19th of October. So we have TV ads, radio ads, we have it far and wide. So hopefully you won't be able to step out your front door without seeing the key messages linked to that. And a lot of it was also balancing off, making sure we didn't create too much demand for the 111 system without it necessarily having the capacity there to answer the calls. So the 19th of October is where they then have their additional capacity in the 111 service. So it's been a fine balance, really fine balance, but from the 19th of October you will see it everywhere, or you should certainly see it everywhere.
Thank you, Claire.
Thank you very much. Thanks.
Leslie, happy with that, or any supplementary, Leslie?
No, I'm fine with that. Thank you.
Chair, Councillor Jones wishes to speak.
Yeah, carry on. Councillor Jones. Hi, Veronica. Can't see you. Veronica, would you like to come in?
Yeah, sorry, I didn't have the microphone switched off. I apologise. So is it okay if I ask a question?
Yeah, by all means.
I'd just like to go back to Councillor Bowman's question about the discharge into potential into care homes. What you did say was that you'd have that conversation, but you also said that you can't hold on to a patient who's medically fit. can we just have some assurance? Obviously, we're doing our best to make sure that we've got proper infection control within the care homes and everything we can do to prevent the spread of the virus. So can I be sure that you will have that conversation? You know, that you will definitely have an answer as to where they're going, not just
Absolutely.
we didn't get the answer, so they've left. Yeah.
No, absolutely. We wouldn't be discharging anybody. And in fairness, the homes are very good in having that conversation. They want a full handover, so it's not a one-way we discharge and we've got to go. It's an absolute two-way conversation. It's in nobody's interest for a home to have an outbreak, neither the hospital nor the home. It's something, they're a most vulnerable group, and it's the group that we want to protect. So absolutely can provide that reassurance that it's a two-way conversation, and that's where we've developed some of our relationships, because it's where some homes are more comfortable with that because of the layout of their homes and others aren't, and that there's not a hard and fast rule just because of that, because it's a joint decision.
Okay, thank you. Thank you, Chairman.
Thanks, Heather. I can't see any more councillors.
Councillor Dunworth has her hand raised.
Yes.
And there's Kath McVoy.
Yeah, I've got. Yeah, Susan.
Yeah. Is this? I'm just wondering if the issue about discharge to homes, if that's a change from what happened the first time round, because it was my understanding that people who were COVID positive were not discharged into residential homes in Northumberland. They may well have been in North Tyneside, but I didn't think they were in Northumberland. And I would always have a bit of a concern about homes feeling pressured to take people back, and the level of care that they were able to provide, nursing care if somebody's got COVID, as opposed to their care being received in hospital.
Thanks, Susan. Claire, or who wants to take that question from Susan?
I think, sorry, Chair, I was just going to come in after Councillor Bowman and Councillor Jones were conversing there, to say, just to offer some reassurance that we are in communication and regular communication about the best way to discharge our patients back into whatever provision is needed. And although some of that is a little bit fluid currently, we are in conversations that no patient will be discharged if they're not medically fit to do so, but also without the consent of the care home of where they're being discharged to. And I think that's the important bit, because some of our care homes have facilities that might enable them to be isolated. Some of them don't, and absolutely we wouldn't be looking at discharge where that's not feasible. But we are in conversations about having some arrangements in place that will allow us to place some of the patients who may well become residents before placing them back in whatever care home they may have come from.
Great.
So I suppose my question still remains, Chair, that if particularly elderly people are suffering from COVID, I would class that as a medical need, not a social care need. So it isn't just about having a room that they can be isolated in. It is actually the standard of nursing care that they would receive. So I'm left with more questions after this meeting than I had before it, actually.
Does anyone want to come in?
Sorry, it's just Bijou here. Say, we wouldn't be sending anybody home who required that medical attention, who were deemed unwell with COVID symptoms. They wouldn't be discharged, even if we park the nursing home even back to their own homes. If they were unwell, we wouldn't be discharging them.
Yeah.
Oh, there are a number of patients that you can still screen positive for COVID and be well again. It's a long burn in terms of some of the symptoms, the fatigue, the breathlessness. You're not necessarily unwell with it, but it takes a long recovery period for some patients.
Thanks for that. I mean, Susan, are you happy with those answers? It's such an important question for ourselves and our residents that if you're not happy, if you want to ask more questions, please feel free, Susan.
No, I don't think at this meeting, but I think it is something I'll pick up outside of this meeting. Okay.
Great. Thanks, Susan. Heather, I can't see anybody else who has the...
No, I can't see anyone, no.
Great. Thank you, Laurie and Bijou and Claire for that. It's a really good and informative report. So thank you very much for all the work you've done on that. Thank you.
Thank you.
I think Chris has Lisa Quinn joined us.
She has, yes, Chair.
Yeah, great. So we can go back to item number 6, which is the quality account presentation.
Thanks, Chair. I believe I'm going to try and present my screen. So if it doesn't work, just hang on there and I'll try and sort it out. If you can just let me know if you can see it. Okay, are you able to see
Yeah,
that?
that's come through.
Great. Okay. So thank you. Thank you for inviting me along. I'm hopefully going to spend a little bit of time just going through the Cumbria Northumberland Tyne and Wear quality account. The presentation itself covers the launch of this year's quality account, a bit of a reflection on our progress made last year, but also sharing what our priorities are going to be in 2021. We have published our draft account on our website. The link is there. I can send it out separately as well if members would like to go and have a look at it in more detail. And if members or the committee as a whole have any comments, if I could receive them by the 30th of October, that would be much appreciated. If you need a little bit more time, just please get in touch and I'm sure we'll be able to accommodate that if needed. Thanks. So just a little bit about the Trust. In terms of the organisation as a whole, our geographical cover has changed from the last time presented to Northumberland. And on the 1st of October 2019, the Mental Health and Learning Disability Services for North Cumbria were transferred into the Trust, and we became Cumbria Northumberland Tyne and Wear NHS Foundation Trust. There were a number of outstanding actions with the CQC in relation to North Cumbria, and I'm pleased to say we've started to make some really good progress on those areas, and we're working with the North Cumbria locality, the CCG and partners in that area to address the outstanding issues with the Care Quality Commission pertaining to North Cumbria. In relation to the rest of the Trust, what I'm going to describe as the old Northumberland Tyne and Wear footprint, we continue to maintain an outstanding rating with CQC and a snapshot that's shown in that presentation. So just moving back and looking back over the last year, 1920 does feel to be quite a strange time for us. We've just heard a lot about how we're preparing for winter, but also living with COVID as we have through the whole of this year so far. But in terms of quality priorities, we did set ourselves 4 priorities for the year 1920, and I'd like to give you an update on where we are against those particular priorities. So the first one is about improving the inpatient experience, and there was 4 elements to that really. We wanted to continue to monitor inappropriate out of area treatments, and I'll say a little bit more about that on the next slide. We wanted to look at our bed occupancy, so whilst monitoring who we were placing outside the Trust, we will also want to make sure we weren't creating greater pressures by reducing that on our internal beds. And then we also really wanted to look at the service user feedback as well in relation to the experience of our inpatient services. So just to give you a bit of an update, So we have continued to look to reduce the number of out of area placements, and this is where our service users, let's say from Northumberland, are placed outside of the Trust's footprint. And overall, I would say it is a pleasing picture where we have looked to keep the numbers very low. We did have an increase, but that increase was across the whole of the country during December and January. You know, the Trust's ambition and aim continues to be a target of 0 inappropriate out of area placements. And we do feel we should be able to achieve that over the coming years. So we are planning to extend this quality priority into next year as we've planned. We set this as a 3-year priority, so our aim is to get to 0 by next year. In terms of inpatients, in terms of people in our hospital, we have seen a reduction in pressure over the last 4 quarters in both adult services and in older people services. We've shown the figures including and excluding North Cumbria because obviously the bed base did change in Q3, which just sort of changed the picture for the whole trust. But I'm pleased to say during this period of time we did see a reduction. We are feeling a little bit pressure as I sit here today in our inpatient pathways, but we're trying to manage that the best we can. In terms of monitoring satisfaction, if you look in the north locality, that's where the services are for Northumberland. We've seen a pleasing increase in satisfaction over the period of monitoring, and that continues to improve. Patient experience nationally, the Friends and Family Test has been paused during COVID, but again, just to give you a sort of real-time update, we have restarted that process internally and we have started asking for feedback now, and we continue to do that through what potentially is going to be our second wave of COVID. I want to move on to the second priority now, and again through the presentation I'll try and give you an up-to-date picture for Northumberland as well. So our second priority, similar to the first one, is a long-standing priority about improving access and making sure people wait as less time as possible for a referral to our services. So at the end of March, we had 61 people that had waited over 18 weeks across the whole of the trust. As I stand here today, there is one person in Northumberland waiting more than 18 weeks, but that is a known position and a mutual position with the service user concerned. In terms of children, again, we wanted to focus particularly on children, and this is the picture for Northumberland. So I'm pleased to say since the 30th of June 2019, there has been no young people, apart from one in December, waiting over 18 weeks. And as again, the current position is there is no young people waiting over 18 weeks. And in fact, there is no young people waiting over 6 weeks in Northumberland now. And the average wait to treatment for young people in Northumberland is now 2 weeks, which is the best that we've got across our whole footprint. So there's been a lot of excellent work done jointly with partners to reduce the waits for young people in Northumberland. In terms of the third priority, we were asked to look at an impact on sickness on quality, and we did some very focused work. I'm going to sort of move over this quite quickly because it was in a bit different locality. So it was actually in our Sunderland locality, but the results of the analysis that we didn't really give any I guess correlation between sickness and quality. So we're going to continue to look at this, but not necessarily have it as a quality priority, as we feel we really want to focus on the inpatient experience, the waiting time, but also human rights, which I'll come on to in terms of where we're going next. The last quality priority for last year was around equality, diversity and inclusion. And again, we have rated ourselves as working on with this rather than complete the work. So we have described it as partially met, and we'd like to continue the work around equality and diversity and inclusion into next year, but with a real focus on human rights. So next year, as I've said through the presentation so far, we'd like to continue to work on improving the inpatient experience, getting to a point where we have nobody inappropriately placed out of area, but also receiving a good experience within our internal beds. We want to continue the work on improving waiting times, maintain the position around young people, but improve it for adults, moving that 18 weeks down as far as we possibly can for adults and older people too. And I'd like to describe a little bit further the work around equality and diversity and a focus on human rights. So what we did around the new priority on human rights is we engaged with staff, service users, carers. We invited partners and stakeholders to a series of events. And the feedback we got was that the general feedback we got was, people wanted to feel listened to, communicated to, and they wanted to have regular events in relation to looking at this particular issue. So as a new priority, we've set ourselves quite an ambitious requirement around human rights. And this slide really just highlights the various initiatives we'd like to do through 2021 around human rights. It's such a massive topic area, and it's very specific to the various different settings we have. So the issues in the community will be very different, I guess, to the issues of a medium secure unit or somebody within our psychiatric intensive care unit. So we want to make sure our actions are appropriate and our actions are specific to the particular services that we're providing. We want to do this in an engaged way and work with our service users to develop the principles around human rights. So that's the end of my presentation. I'm very happy to hopefully stop sharing my screen to take any questions.
Well, thank you for that, Lisa. We've got Susan and then Liz.
Hi, Councillor.
Thanks, Chair. A couple of questions. First of all, congratulations on reducing the waiting time for young people, because that has been a massive issue for lots of families for a long time. And I know waiting times for anybody is difficult, but if you just think of people's proportion of their lives, if they're spending that waiting for treatment. So I wanted to say well done on that, but also what lessons are learned, because you talked about sharing some of that learning in adults, and also about how embedded that is, because we all know sometimes we hit targets on something, and then when our attention shifts to the next target, the first one sometimes slips. So just a bit of reassurance on that, please, Lisa.
Thank you, and thanks for the feedback. I guess your comments resonate with, I guess, where we are and why we want to keep this as a quality priority, because it could so very easily slip in terms of it. So we do want to continue to monitor access and to report on it publicly to make sure that we don't slip back in relation to where we've got to. In terms of young people and the progress we've made with the young people services, there are lots of lessons and lots of good practice that we've learned from that process. Key things I would draw out is partnership working with primary care, understanding the referrals, making sure people don't get bounced between services, being clear about the expectations with families that a young person will be supported, they'll be assessed, they'll provide a treatment practice, but then we will ask people to work within their families and within their networks on, you know, on a recovery model rather than staying in service for a long time, which is what we had before. So there are lots of different and lots of good practice. I have to say, we're not in that position across the whole of the trust. We've got very long waits in other localities, so we are learning from the progress we've made in Northumberland and trying to apply that across the patch, but recognising that, you know, in all of our localities, we are predicting a surge following COVID and the need for support for mental health and wellbeing, and particularly with young people going back to university, young people going back to school, we are seeing referrals increase. So it's absolutely in the focus of our minds all the time to maintain the level of access we've got in Northumberland, but also spread that learning across the trust, because as I say, we're not there everywhere. I have to say, where it's a very different picture across other parts of our localities.
Thanks.
Yeah, that's really helpful, and I think it's really good that we're thinking about what the effects of COVID on young people, because I think sometimes we overlook that, but the psychological impact of this last year that is ongoing, I think is absolutely massive. So thank you. Chair, can I say I'm going to have to leave shortly because I have another meeting, but I'll stay around for another couple of minutes, okay?
That's fine. Thank you, Susan. Les, you had...
Yeah, thank you, Chair. Lisa, can I ask about emergency beds? What's the situation with that? Is there plenty capacity to take patients into mental health service at a minute's notice? Is the pressures on there? Is there any issues that are highlighted because of lack of facilities? Can you feed me with that sort of information?
I will certainly try. So this is really the focus of our first quality priority about improving the inpatient experience. And Councillor, the beds that I guess you're describing as emergency beds is our assessment and treatment, acute assessment and treatment service. So this is when somebody is poorly in the community and is assessed as needing a bed. We are trying to ensure that when that bed is needed, it's accessed locally. So at this point in time, we are managing to place people locally as soon as possible. And it's not necessarily always at a minute's notice, I have to be honest about that, but it is within that day and certainly within a matter of hours following assessment. I did stress through the presentation, I have to be honest and say we have pressures in our beds at the moment during COVID, but we're aware of those pressures and we try to look at the flow through those beds. So not necessarily always just looking at what we need to access, it's also about how do we get people out and moved on through their pathway through discharge as well to create that capacity. So this is absolutely a focus for us. It is something that we're working on. The first slide I showed you about the out of areas, that's where we can't find a bed locally and we've had to place somebody out of area. As you've seen that slide, the numbers are very, very low. So I can tell you today across the whole of the trust, we have 2 people placed out of area. But I can also tell you that I've got constant emails telling me we've got bed pressures and we need support from our partners to help with that flow. So it is very much reviewed. I'm not going to tell you it's perfect because it's not, but we are trying to do our best with that and work with our local authority colleagues to improve.
Thanks a lot, Lisa. Les, are you happy with that?
Yes, Chair. I'm really pleased that you're working really hard on this issue. It was something that was highlighted at the beginning of last year, and I'm really pleased that you're taking action to rectify it. Thank you very much.
Thanks for that, Les. Heather, I can't see any other councillors. Sorry,
Councillor Rigby.
Yeah, Leslie, just seeing you.
Thank you. Yes, thanks, Lisa, for the presentation. I want to come back to the equality, diversity, inclusion and human rights.
Yeah.
You've got a bullet point saying to identify human rights advocates. I was just wondering have you got a pool of people? Are they going to come from the service user or the carers or staff or, one of each? I just would like a little bit of clarity, please.
Yeah. So we're reaching out, Councillor Rickaby. We haven't determined a particular group, discipline, or whether it's a member of staff. We're looking for people with enthusiasm, people who want to work with us on this issue. We do have a number of staff champions already. But we've also got some very keen and enthusiastic service users and people with lived experience that want to get involved as well. For me, and again, I touched on it very briefly during the presentation, people's experience of human rights is it's different when you're in the community compared to when you're in an inpatient area. Something as an example, in the community, your right to fresh air is a given, isn't it? When you're in a medium secure unit in a seclusion facility, your right to fresh airs are limited. And that for me is this, it's very stark, the difference in terms of how you approach human rights depending on your own experience and where you are in your recovery and treatment within mental health. So we want to make sure we work on the things that are important to those groups of people working together. So the advocates and the champions we're looking for is from a diverse range of experiences and settings to make sure we get the right breadth of focus into what we're doing here. It is challenging, but our medical director is leading this piece of work and is incredibly enthusiastic about delivering and continuing to deliver on this particular topic.
Thanks, Lisa. Leslie, do you want to come back with a secondary question?
Not a question, just to endorse what Lisa's just said. It's an interest, equality and diversity that I've had for many, many years. So I do appreciate the difficulties around it and people's perception. But it's heartening to hear that you are going to try and have a broad church, and hopefully, whether anybody will ever get it right, that is possibly another debate, but all power to your elbow to do as much as you possibly can. Thank you.
Thank you.
Thanks for that, Leslie. Heather, I can't see anybody else. Can you see any?
No.
Great. Well, thank you very much, Lisa, for the again, another very informative and excellent report. Thank you very much for your presentation.
Thank you. Thank you very much for your time.
You're welcome.
Bye, everybody.
Right. Item number 8, report from the scrutiny officer on a work programme. And Chris, I think you're taking this one.
I am, thank you, Chair. The work programme is, as always, it's there for members to comment on. If there's anything any members would like to be considered for the work programme, they just have to reach out to either myself or the Chair, and we can discuss items to be added. The next month, we will have Newcastle Hospital's quality accounts and a post-scrutiny report from Cabinet on the COVID recovery. In December, it's not on the work programme, it should have been added, but NIAS will be given their quality accounts in December as well.
Great. Thank you for that, Chris. No comments. Item 9. Next meeting is the 3rd of November 2020 at 1 p.m. Item 10, urgent business. I don't have any. Are there any councillors with any urgent business? Again, I can't see anybody. Heather, can you see anybody who's raising their hand?
No, Chair.
Great. So at 2:10, I'll close the meeting. Thank you very much, councillors, for your time and some excellent questions. Thank you.